apologize for the technical difficulties on our end. Thank you for joining us for today's NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue. Second, please locate the chat box on the left-hand side of your screen. If you have any questions, type them in the chat box and we will address those at the end of today's presentation. Lastly, if you've requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended. All CEs will be emailed out within the next week. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our speaker, Dr. Trudy Larson, who is the professor and founding dean of the School of Community Health Sciences at the University of Nevada, Reno. In addition to serving as medical consultant for immunizations for the Washoe County Health District, the former chair of the Nevada State Immunization Advisory Committee, and being a member of Immunize Nevada, Dr. Larson has conducted research and outreach activities throughout our state in an effort to promote higher immunization rates across the lifespan. Thank you for joining us today, Dr. Larson.
My pleasure to be here. So today we're going to talk about influenza, and it is the season, with some early reports now of influenza cases starting to trickle in. But I think, as we all know, this usually goes through February and March. So specific today, I am going to talk about healthcare professionals and influenza vaccination. And we're going to go through some evidence to support the recommendation for health professionals to get immunized, and then also discuss some ways of increasing immunization rates in a variety of healthcare settings. So let's get started. I love this slide because I think it shows when people sneeze or cough, these particles, and if you have flu, they're all infectious, reach a broad range in the air. They drop out so that folks wandering by who touch things or rub their noses and their eyes are as likely to become infected as those within this sphere of particles. So influenza is definitely a respiratory acquired infection and highly infectious. The problem with influenza, of course, is that it is responsible for hospitalizations and deaths every year. This is principally due to the fact that we do not have long-lasting immunity to influenza. This is a direct result of the virus, which we could probably call promiscuous in terms of its ability to recombine with other influenza RNA particles from other species, as well as undergo spontaneous genetic mutation, so that every year we see a little bit different version of the influenza virus, sufficient to allow for a lot more infections to occur, even with immunization from the previous year. So that is an important reason why annual vaccination really is necessary to address influenza infection. The hospitalizations and deaths that occur every year vary by population. Years where we have H1N2, I should say H3N2, we have higher rates of hospitalization. H1N1, classically we get more young adults and teens that get infected. The H3N2 often will target babies and those who are older. So these hospitalizations and deaths do vary every year, but they are consistently present and really are far higher than any of us would want. Influenza infection is insidious in the sense that people are infectious before they get symptoms. So most healthy adults can infect others beginning before the first day of symptoms and up to 5 to 7 days after becoming sick, because the virus is multiplying and is present as our immune systems try to corral that infection and make us better. The other part of this, of course, is that some people never get flu-like symptoms. However, they are infected. And so these asymptomatic folks, or folks who maybe have very mild cold symptoms, are equally infectious, and so can still spread infection to others. From infections, we know that certain folks are at risk of more serious complications. And the primary complications from influenza, of course, is pneumonia. And so folks that have chronic lung diseases like asthma or chronic obstructive pulmonary disease, or who have diabetes, heart disease, neurological conditions, pregnancy, are at higher risk for the complications of influenza. And so we have a population that's more susceptible and likely to have complications. We have people who could become infected without symptoms. And so the ability for this virus to transmit becomes very difficult to control if you only look at physical barriers. And because we never know who we might be standing next to in the elevator. So really, vaccine is a significant answer to really addressing the morbidity and mortality associated with influenza. And because healthcare workers can care for or live with or work with people at high risk for influenza-related complications, it's very, very important for them to get vaccinated annually. So this complicated slide, which if you blow up you can see a bit better, talks about the causal transmission pathway of influenza. And so on your left side in the left-hand upper corner, you see the influenza virus. It is able to infect any susceptible host, i.e. a host that does not have an antibody or immune protection against that specific virus. And so we have 3 healthcare professionals that are noted here. In the red is the infected healthcare professional who's symptomatic, and classic symptoms for influenza are influenza-like illness, which is a febrile cough, cold related symptoms. And then we have the healthcare professional with mild symptoms, like a cold, and then we have the asymptomatic but infected healthcare worker. And so once these infections get put into place in these individuals, you can see where this can be transmitted in a variety of scenarios. And so you can see that at work, those who are infected, those who have mild symptoms, have a higher risk of transmission to contacts like patients or other healthcare professionals seen on the right. If they're infected, even those who are asymptomatic, with the duration of exposures, there's a risk of infection. As we know, many healthcare professionals go to work even when they have a cold, simply because the dynamics of healthcare and the shortages of many positions make it difficult for them to not come to work. And so they do not put up that physical barrier to infections. And as you look to the right, there are a number of consequences then that occur because of patient or their other healthcare professionals becoming ill. We have higher rates of infection with healthcare professionals and having to be absent. We have a number of impacts on patients that have to do with mortality and morbidity, and particularly in long-term care facilities where the consequences of influenza are more prominently seen in terms, because they're often frail, elderly adults, and they do not do well. So this whole causal pathway, you can see for a variety of reasons, whether you're symptomatic or asymptomatic, healthcare professionals have an opportunity to infect a wide range of other people that they work with or who they take care of, and that the consequences for that can oftentimes be quite dramatic and severe. So the outcomes for vaccination are pretty important then if we look at that causal pathway of transmission. So number one, vaccination will prevent healthcare professionals from illness and therefore from absenteeism, which is a really critical factor in our ability to deliver healthcare. It can prevent transmission of influenza from the healthcare professional to patients and other healthcare professionals. So they'll stay healthy and they will not transmit. When a healthcare professional group is vaccinated, it reduces hospital-acquired influenza cases. And we all know hospital-acquired infections are monitored closely and often have consequences for payment because it's hospital-acquired. Vaccination also has been shown to reduce mortality and morbidity of patients, including influenza-like illness, and we'll go into this a wee bit more, just that whole illness complex and mortality just by influenza vaccination. And then adding other infection control measures also improves the effectiveness of vaccination. For example, reducing what they're calling presenteeism, which is being present at work when ill. I love it when we make up words to explain a condition. So presenteeism, being present at work when ill. All of these factors are influenced by influenza vaccination. So one of the very important things to identify is that studies have shown that healthcare professionals, because they're usually healthy adults, produce better immunity and therefore better vaccine efficacy than patients. Healthcare professionals are healthy adults usually, and patients often have conditions that make the effectiveness of the vaccine less robust. For example, the elderly do not respond as well, do not make as a large an immune response. Those who have chronic conditions also do not make as good an immune response. And of course, babies are even more difficult. So if the healthcare professional is more likely to develop immunity than patients, we can see where the focus not only on patients to try to prevent them from getting infections, but clearly healthcare professionals have a really strong role in those immunization efforts. The other thing about influenza vaccinations in healthcare professionals that has been shown in studies to reduce influenza-like illness and all-cause mortality in patients. So let me talk a little bit about this finding as an outcome. ILI, or influenza-like illness, is simply that. It may or may not be due to influenza, so can be caused by a variety of other respiratory pathogens causing the exact same symptoms. So we do know there are some very interesting consequences of influenza infection. One of them have to do with respiratory, the respiratory tract dysfunction that can occur with influenza and then predispose to secondary bacterial infections or other even viral infections. So we know that's one mechanism where if you get a vaccine, it reduces influenza-like illnesses. But these other infections that are present have been shown to be reduced overall with vaccination. Again, because not getting influenza may reduce the disease or disruption of the respiratory tract. So you can see where finding that has influenza vaccination associated with all-cause respiratory illness suggests that there's that relationship between influenza and more serious secondary complications. The other thing is that vaccination protects against influenza infection and disease. So all-cause mortality in patients is actually reduced with healthcare professional vaccination, because some people with chronic diseases are so frail that one infection, influenza, can put them, they can decompensate and they can actually die. And so another outcome that has been linked to healthcare professional vaccination with influenza is both of these outcomes have been reduced with the use and increased use of influenza vaccine for healthcare professionals. All of this data leads to ACIP's very strong recommendation. Number one, that all persons older than 6 months should get an annual influenza vaccination. And number two, that they recommend that all healthcare professionals receive an annual flu vaccination. This recommendation has been made for a lot of years, and so we all recognize that with that evidence suggesting a lot of good outcomes, not only for healthcare professionals, but also for their patients and the sites where they work at. The biggest problem is figuring out how the best way to make this happen and to increase rates of influenza vaccination in healthcare professionals. So how are we doing? So if we look at our country's Healthy People 2020 goal for influenza vaccination overall, like in the general public, we haven't made anywhere close to that level. But for healthcare professionals, the goal is to have 90% of healthcare professionals vaccinated with influenza vaccine. And these are Nevada data, and I think it's illustrative of a lot of other states where they do not meet the Healthcare People 2020 goal. In Nevada, for all healthcare personnel, the rate is 78% compared to the U.S. at 89%. So the U.S. overall has been pretty close to that 90%. And if you look at licensed independent practitioners, so these are maybe independent offices, for example, private practitioners, the rates are much, much lower. In Nevada, 42% rate of influenza vaccination in that group compared to the U.S. of 75%. So clearly, there's a lot of room for improvement to reach this goal, which again is designed to not only protect the healthcare professionals, but their patients and improve the health at their workplace site. So if we look at a study that was done in 2017, they looked at early season flu vaccination. Now, the reason early season flu vaccination is a really good marker is because we know that the onset of influenza season might be variable, and we know that the duration of protection is for months, not 2 or 3 months, but for many months. And so early vaccination will really help prevent early season illness and transmission from occurring. So we really want to look at that early season flu vaccination as an ideal time to get those influenza vaccines, that vaccination accomplished. So when they did this study in 2017, it was national, it was highest among healthcare professionals whose employers required influenza vaccination, and that was at 88.4%, so almost at the Healthy People 2020 recommendations. If there was just a general recommendation from their employers, it was at 65% that they be vaccinated, and those who did not have an employer requirement or recommendation, they were at approximately 30%. So big differences resulting from differential policies by employers. More data from that same study showed that the 17-18 influenza rates were really quite similar to the rates before. So we're not really seeing any improvement in this particular metric and haven't for years. There was also quite a difference in the occupations who were more likely to be immunized. So you can see on this slide that early flu vaccination was highest among pharmacists, which I was really grateful to see, principally because our pharmacists are now excellent partners for us in delivering immunizations, not just influenza vaccinations, but also a variety of other vaccinations like DTP. But the influenza one is particularly a popular way for pharmacies to get involved in immunizations for everyone. In our local grocery store, in fact, they give out incentives for people who can show they got their influenza vaccination at their pharmacy. A great job of providing another site for vaccination to occur. But pharmacists themselves were higher than physicians at 82% and nurses at 81%, nurse practitioners, physician assistants at 80%, and other clinical personnel at 75%. So those are clearly the highest ones, and I think that makes a lot of sense. If you know those professionals are going to have contact with patients who are potentially quite ill, and so that makes sense that they would be more aware of their need to vaccinate. And it was lowest among administrative and non-clinical support staff at 61% and assistants and aides at 56%. That's a wee bit concerning because assistants and aides can actually have a lot of frontline contact with patients who may be chronically ill. So different groups have uptake of influenza vaccination in a different fashion. It also varies substantially by the site and where they work. It's highest among those who work in hospitals, and I think that makes a lot of sense. Hospitals have been sort of the first large employers that have looked at required influenza vaccination for a variety of reasons, which we'll get into, but they have the most exposure and the most interest in having a healthy environment. So that makes a lot of sense among those healthcare personnel who work in hospitals. For those who work in ambulatory care, in this same 2017 study, it was at almost 69% for healthcare personnel. For those who work in long-term care facilities, it was at 58.5%, which I'm going to point out is really a very difficult figure if we really want to impact morbidity and mortality. And then other settings, some were similar at 56%. So again, the setting, it varies by setting, it varies by health professional, and it varies by the degree of recommendation. So as we look and see, well, for all those percentages of our healthcare professionals who are not getting immunized, what is their reason? The most common reason reported for not getting vaccinated, and you shouldn't be surprised by this, is fear of experience a side effect or getting sick from the vaccine. I think we all deal with this myth. And the myth of influenza vaccination is that, quote, it causes the flu, unquote. Of course it can't, because our vaccines that we use in adults is usually the killed variety, so there's no way it causes infection or causes influenza. Now, if we have a good vaccination, you might have a little malaise or other symptom, sore arm, from the immunity being developed, but that is not getting the flu, and it's really a minor side effect. If any of you have had the flu, and I did many, many, many years ago, and I was really, really sick and missed a lot of work, got secondary complications, and ever since then, I have gotten my influenza vaccine. So for me, there is no amount of a sore arm that's going to keep me from getting my vaccine. But I think that the word needs to get out is that no, influenza vaccine does not cause the flu, and these side effects are minimal. In truth, our vaccines are hugely safe, and they have to undergo sufficient testing to prove that they're safe. So that particular story and message really needs to be part of our messaging and marketing when we go to look at required immunization programs. So here's another, among that same study in 2017, which was a huge study, which is why it's a wonderful one to quote, and it's recent enough to give us good data. The reported reasons for not having received a vaccine yet, so that, again, this was early season vaccination rates among those who planned to get a vaccine. So these were not the reasons that people didn't get vaccinated and didn't intend to. These are the reasons that people gave for not having yet gotten their vaccine. And you can see at the very top of the list is, I haven't gotten around to it, or I haven't had time. So if you're looking to create a program that vaccinates the vast majority of workers, clearly that has to be at the top of the list as an issue that needs to be addressed. And we'll go through what that really looks like in practice. My employer offers the flu vaccine, but it is not available at work yet. Another significant problem. Flu season hasn't started yet. As you know, we need 2 to 3 weeks after immunization to develop a really robust response. So we really don't want to wait until the flu season starts to get vaccinated as healthcare professionals. My employer does not offer the flu vaccine, another significant barrier. They offer it, but it's not at a time when I'm working. My employer offers, but does not allow time for me to get it, another barrier, an employer barrier. Flu vaccine costs too much. If it's not being covered by insurance, I would agree with that. And any other reason, there's a whole variety of those. But I think you can identify here that these are systemic barriers when you look at reasons people who want to get vaccinated don't get vaccinated, systemic reasons that can be addressed in a variety of ways. So one of the ways it is being looked at is, of course, a required or mandatory influenza vaccination policy by the employer. And here's a study that looked at the requirement for vaccination and then those who were vaccinated with or without that, and they did it by work setting again and sort of looked at these percentages by site, and it sort of puts everything together. So those percentages of vaccinated healthcare professionals who had whose employer required it were far higher to be immunized in every single healthcare setting, whether it was hospital, whether it was ambulatory care or physician office, whether it was a long-term care facility or any other setting. If it was required, it made a big difference. If you look at compared to where it was not required, those are statistically significant variances between the percentages of uptake. So clearly the requirement really makes a big difference in every single healthcare site as to whether a healthcare professional will actually get vaccinated. There's another way of really looking at it. For required, 88.4% overall for all healthcare personnel. If it was recommended, 65%, and if it was neither, it was only 30%. Clear indication that if we want effective immunization programs, that the voluntary nature of many of them will not suffice to bring the level of protection up high enough. So let's look at the success of influenza vaccination in a variety of health settings. So one study that was done in a children's hospital, it was a randomized, double-blind, placebo-controlled study. So this is the most rigorous studies that are conducted. looked at flu vaccination, and they particularly looked at the associated absenteeism from respiratory infections. This was not linked to flu infections specifically. So this is where this gets very interesting. Many of the studies do not look at influenza infections. So they do not culture for influenza in those with respiratory infections, but they look for all respiratory infections. And so in this one study in a children's hospital, and you can imagine a children's hospital, the risk for getting flu would be pretty high, simply because children are not very good with their respiratory secretions. We know that. And they tend to be more vulnerable and much higher rates of infection that they can pass to each other and to their healthcare professionals. So they show with flu vaccination in healthcare professionals, it was associated with a 28% reduction in absenteeism from respiratory infections overall. So just this one impact suggested it was much broader than just influenza infection. There was also a 3-year randomized double-blind placebo-controlled study that looked at vaccinated versus unvaccinated, and showed that those personnel who were vaccinated had 29% fewer cumulative days of febrile respiratory illness. So these are all-caused respiratory illnesses, not just influenza, and a 53% fewer cumulative days of work absence. And for all large, even small employers, absenteeism is a really big problem in order to deliver good care. So again, vaccination was associated with 2 very important outcomes. Studies in long-term care facilities have been even more obvious. Staff vaccination in these long-term care facilities has reduced all-cause mortality. So all-cause mortality means deaths due to anything, heart attacks, strokes, everything. That staff vaccination reduced all-cause mortality in patients. It reduced influenza-like illness, again, that constellation of respiratory symptoms, and reduced hospitalizations among patients. Long-term care facilities tend to have higher rates of influenza vaccination and the consequent complications of those. So identifying that a single act of influenza vaccination reduced all of these parameters is a very strong argument for all methods of increasing staff vaccination. In acute care hospitals, so these are in a variety of different kinds of hospitals. In another study that was in acute care hospitals that involved many hospitals, they showed an inverse relationship between influenza vaccination. So the higher the influenza vaccination of healthcare professionals, the lower the rates of nosocomial infections in patients. And by nosocomial, we're talking about infections acquired at the site. Usually we look at, this would be hospitals, so nosocomial infections would be hospitals acquired at the hospital. And so the higher the influenza vaccination rates in the healthcare professionals, the lower the nosocomial infections. These can be related and have been related to enormous economic impact for all of these sites. Nosocomial infections increase hospitalization costs enormously. Readmissions for nosocomial infections will not be reimbursed by Medicare. And now looking at accreditations of hospitals, they're beginning to look at these nosocomial infections and vaccination rates as markers of quality. So it's not just we care about our patients when we care about each other by being vaccinated, but it also has a really significant economic bottom line. This is one study done many, many years ago, but these are the studies that are done in long-term care facilities have been very consistent in showing the same outcome. if you look at the difference between the outcomes for patients, so we're looking at outcomes for patients among nursing home residents, that's the patients, and looking at influenza among those who are vaccinated versus unvaccinated, and these are healthcare professionals who are vaccinated versus unvaccinated, you can see that illness decreased with vaccination, and that hospitalization, pneumonia, and death was decreased with vaccination. This death is all-cause mortality. Those are very impressive statistics, and those are percentage decreases, almost half, so they're all significant differences just from implementing influenza vaccination in healthcare providers. So how does this get done? Again, both required and recommended recommendations from employers make a big difference in whether healthcare professionals get vaccinated. And so ways to look at how to make this happen, in addition to that requirement, is employers should offer flu vaccination to all of their employees. The best way to do this, as you noted from some of the concerns voiced by people who are having difficulty getting vaccinated, is that influenza vaccination is offered at the work site over multiple days and through all shifts. So access is a barrier for employees, and this is one way to reduce that access barrier significantly. These vaccinations should be free of charge, and they need active promotion. So again, whether it's a requirement or a recommendation, there needs to be a good marketing campaign about when and how to get these vaccinations so that employees don't have barriers. Nobody likes to go in and get shots. So I think overcoming that just initial objection by making things easy is really an important part of improving our vaccination rates overall. Educational materials need to be provided, and this really needs to address the questions that people have about safety, about side effects, about their misperceptions of effectiveness, because remember, there's a substantial difference between the effectiveness of flu vaccines in healthy healthcare professionals and patients. And that one study identified that the efficacy or good vaccine antibody production in healthcare workers was 89% had good vaccine efficacy versus 42% of patients, which I think, again, it just really emphasizes the fact that even though we try to get all of our patients, hopefully preventatively before the season, vaccinated, that this healthcare professionals, they have a much higher rate of vaccine efficacy and protection. So all of those questions, all of those concerns really need to be clearly stated in educational material. And I always, and when I talk about healthcare professionals, I'm not just talking about nurses and doctors and those who, sort of are more traditionally seen as professionals interacting, but actually the whole team. So if you have social workers, if you have nurses' aides, if you have front office staff, everybody who works where air is being exchanged by multiple people, including patients, those are the folks that need to be targeted, and they really need to get education about why this is such a big benefit to them and to the patients or of that hospital. So that becomes very important, that material be at the right reading level, that it be very clear, and that it be consistent and truthful. And then on the policy side of things, there's always this, how do you implement mandatory influenza vaccines? And to really do that, when we do anything that has to do with mandatory, we need to really look at where access is and how to make sure that is guaranteed. There will be those who medically cannot get the vaccine. It's an extraordinarily small percent, but there always will be some, and you need to have what is the option for them? And most of the time in most facilities and practices, that's a mask. So, people who are not vaccinated wear a mask. And long-term planning is needed to do this. So if an employer is considering either going from recommended to required or going straight into required, it becomes very important to plan this well in advance to make sure that all the specifics of that delivery process are accomplished to make it happen. So let's look at some of those real specifics. And this is my last slide. So hopefully we'll have an opportunity to have some questions. So that careful planning, what does that look like? The careful planning is, what does mandatory mean? Is this for everybody? And who is that everybody? Again, what people in the healthcare team are going to be required? Is it everybody who works in that hospital setting? Is it just those who have patient contact? And those are good questions. And if you ask me, of course, it should be for everybody, because the issue here is not only do healthcare professionals who are ill infect patients, but they also infect each other. And so the absenteeism or the passage of influenza on to somebody who does have more direct patient care becomes a consequence of that. If you make it mandatory, what are the consequences? And do they lose their job if they don't do that, or are they allowed an out with other kinds of consequences? That's a real important piece that people have to decide about. Educate all those who will be affected, including direct and indirect healthcare employees. That's what I just talked about. The guard at the door, the cafeteria workers, the folks in the shops. They all share air with other folks in their sites and with patients. So it's a very broad group that we're going to talk about. Must reduce barriers to getting vaccine and plan for early season immunization as soon as the vaccine comes in, which is usually early October. So that's when this needs to be planned, set up, multiple vaccine sites, free of charge, all shifts, and have a really good tracking mechanism so that you have an opportunity to know who or who has not been vaccinated, particularly if there is a consequence of losing the job, which has been done in many facilities. If you don't get immunized, you cannot work here. So that you need to know, have a good tracking system to make sure you know who has been vaccinated. And if they have a medical reason, that you set up those options for them about what you're going to be able to do to, again, reduce their risk and reduce their risk to others. So this data measures becomes really important. And there's a Community Prevention Services Task Force that has a website that has a lot of recommendations for how you might keep track of this, how to open this up, how to really do the communication, because the communication, of course, will be critical. Not only the materials that people have on site at the vaccine, but preliminary materials. They should have that opportunity to read those in advance, get in for their vaccinations, have that noted, and then be able to track outcomes. So here's maybe more of a challenge to folks who work in large healthcare facilities is like, what are you going to monitor in terms of effectiveness? It may be all respiratory illnesses. It may be a mortality. It may be pneumonia. There's a lot of things to look at. Absenteeism, one that I think is very, very easy to be able to identify. Along with this, other policies that probably should be enforced are coming to work when you're ill, and that's one of the hardest ones to really address in any facility. Now, one of the bigger reasons, not only is this the right thing to do for us, for our patients, but it's also required by CMS now that acute care hospitals, ambulatory surgery centers, and outpatient dialysis facilities all report their healthcare professional influenza vaccination coverage rates for their facilities. So this is now being looked at as a quality measure, and quality measures have a lot of impact on accreditation, and in certain circumstances may be met with fees and disciplinary action if it is not able to be identified. So really important. This is a sort of a common voice throughout. It's the right thing to do. We're going to watch you do it. We're going to measure that you do it. And of course, all of this is legal. So a lot of work has been done in the legal profession to identify that mandatory requirements are indeed legal. Okay, with that background then, I am happy to address any audience questions that folks may have.
Perfect. Thanks so much, Dr. Larson. Before we address the few questions that we have, we'll give a little more time for participants to post those in the question box on the left-hand corner of your screen right above the audience chat box. And while we're waiting for those, just a couple of reminders for you folks. If you have requested continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar has ended. All CEs will be emailed out within the next week. And then if you'd like to view or share this webinar, the recording will be available on the Immunize Nevada website along with information for future webinars. I know that there was a lot of information on Dr. Larson's slides, so we'll be sure to post those as well. Please visit immunizenevada.org/webinars for those details. And we'll go ahead and move right into questions, Dr. Larson. It looks like the first one that was posted was, where do we get the data on whether or not a healthcare worker has been vaccinated?
So if you're, there's a variety of ways to do this. If you're running your own programs, obviously you're going to check them off the list. But most of us have registries, and putting this information in registries is required. So if you get your immunization at a pharmacist, for example, because I think that's the one that might be most difficult to, it should be in your registry. WebIZ, which is the registry we have here in Nevada, actively checks that, and all the pharmacists put that data in, offices put that data in. So I think that is a very good place to check that the immunizations have been done.
And I know from a broader sense for just the National Healthcare Workers Influenza Survey, the National Health Interview Survey monitors vaccination status of healthcare workers by conducting in-person household interviews on a broad range of health topics, including flu vaccinations. And then we also have the Internet panel surveys, which are an opt-in mechanism that the CDC uses to monitor health issues of special populations, including healthcare workers. So they use that as a sample study to be representative of broader vaccination trends in Nevada related to healthcare workers too. So that specifically for these,
Yeah, so there's two levels to that question, and so I think you just identified one. Like when you're looking at national and local and regional statistics, where do those come from? That's where they come from. If you're looking at a specific person and want to know if they're vaccinated enough or not, that can come from registry.
Yes, absolutely. And then we have another question from Janine. She asks, what are your thoughts on various masks for those that do not get the vaccine? Cloth or preference of type of surgical mask? When do they have to wear them? As soon as they get in the building or just when caring for a patient? And what if someone says that they've had a mild reaction to a previous year's vaccine?
Okay, excellent questions. So masks. A regular surgical mask will work. They should don that as soon as they enter and take it off when they leave. So it should be present. So, and I'm going to tell you a little bit about why masks are reasonably good. In other words, you don't need those, the respirators. The masks are reasonably good because one of the major ways that transmission takes place is when respiratory secretions come out and fall on surfaces, and then when people rub their eyes and rub their noses. So when you have a mask on, you cannot rub your nose, which is a really good thing, directly. I've seen people scratch, but anyway, that's a different thing. But basically, a regular mask should be worn the entire time they're in the facility. So not just when they're caring for a patient, because remember, this is airborne. We share air all over, and you cannot tell where that air is, basically. It's a real simple sort of explanation. But that's why it's difficult to say, well, only when you're seeing a patient, because if you're infectious, then you walk outside the door, and then you're spreading virus all outside. So I think that this is really about consistency, about wearing it all the time. And I have to tell you, I heard this from a person, which I love this statement. She goes, when I go to the doctor, I like that there's a requirement to wear a mask if you're not immunized, because it helps me visually see who on my healthcare team cares about me enough to get vaccinated. That's a patient perspective. I thought that was really pretty important. So anyway, any type of mask, I don't have a preference, but they need to keep it on all the time. The other thing that's really important about that whole mask thing is also the hand washing or the hand sterilization. That should happen all the time because, again, our hands are major transmitters. So between those two, that reduces the risk.
And then she asked also, if someone had a mild reaction to the previous year's vaccine.
So a mild reaction is not a contraindication to a new vaccination. Remember, each year's vaccine is a little bit different, and the side effects are not particularly predictable. The only side effects that are medically okay, that really are contraindications for flu vaccine, are anaphylactic reactions, basically. There's still an old one that's a precaution around Guillain-Barré, but that's, again, being looked at more as a precaution and not a contraindication. Those are that's the big one. And so there are very few people who have medical contraindications for this vaccine. And I think that's really important. Again, it's a very, very safe vaccine. A mild reaction, that I tell folks when they have mild reaction that's really an indication that their vaccine is doing its work, that it's inducing immunity, that it's really doing what it needs to do to protect their respiratory health for that flu season.
Perfect. And then we had another question. In regards to interventions to promote flu vaccination among healthcare personnel, how would you suggest healthcare personnel get the flu vaccine when they already know the facts? I'm assuming that if they know the flu vaccine doesn't give them the flu, but they refuse to get vaccinated, would be an example.
Exactly. So that's where required makes a big difference.
Sure.
So for facilities that have mandatory influenza vaccine or required influenza vaccine, that's what makes a difference here, because there is no valid reason for them to not get the vaccine. And so part of, again, looking at that mandate of the requirement is that you have to really clearly state in the policy that everybody will get vaccinated for influenza vaccine unless they have a medical contraindication. And I just told you what the medical contraindications are. They're not very common. And so really then the second part of that is then what are the consequences for not getting it? And most folks have chosen to just go with the program, even though they might be enamored with getting the flu vaccine. That requirement really makes a difference, even from the recommended, because you're talking about somebody where maybe in a site it's recommended that everybody get vaccinated, but you saw the statistics. With when it's mandated, it's almost 90%. When it's only recommended, it's 65%. And so there's that big group that may know that it's safe and it's just sort of a hassle, and I'm not all that interested. Whereas when it's required, it really brings it front and center as a very important infection control process for any size facility.
Right, and works the same way as the school requirements would in the in the school systems for with regard to immunization coverage. Rates go up when school requirements are put in place. So yeah, there needs to kind of be that those policies there. That's where legislatively it definitely helps us.
It does help.
Another question. Oh, go ahead.
Go ahead. No, I answered that one. Thanks.
Okay. Next question is, should patients be asking if their care providers or their office staff is vaccinated?
Oh, I love that. Okay, whoever answered that, that's brilliant. Because I'm like I said, that one patient, that's what they said to me, and it's like, wow. I think patients should ask. I think it's an enormous motivating factor that if patients are taking this to heart and they want their facility to provide them a safe environment, that's a really good thing for patients to ask. How it's received needs to be pondered, right? I would hope that the answer to that kind of question is, we require that for our practices, so yes, everybody's vaccinated. We think this is important. But it may be in maybe someplace that's not quite as, they're not right up to date. It may be something for them to consider. We really want to make sure that there are no barriers to patients being comfortable and safe in our environments, and so how we structure that with our infection control processes really makes a difference.
And we're running out of time. We're almost at that 1 o'clock hour, but I just wanted to say to Shoshana, yes, we will be sharing the studies on the slides. We can definitely include references for you, so you can share those with your own colleagues. And then Esther had a question: if made mandatory, how is the facility covered legally, and where can this documentation be found?
So if it is made mandatory, as I said, the policy has to be extremely clear. It has to be, everybody needs to know about it. It is legal to do this. As an employer can require this, especially if they say, if you have a medical contraindication, then of course we'll have an option for you. Many facilities will say, may waffle a wee bit and offer other options, but legally they can do this. And I'm thinking about a presentation from last year's Nevada Health Conference where we had a lawyer come and speak about this. And so it's in employment law, and the CMS data also is available to identify that facilities are now being asked to provide the percent of vaccination as a measure of quality.
Perfect. Okay. Well, that, I think, just about covers it. If you have any other questions that we did not get a chance to address during today's live presentation, please send those to us via the survey. We're happy to get those to Dr. Larson or do our best as the Immunize Nevada team to answer those. And that will conclude today's NILE webinar. Thank you again, Dr. Larson, and to those of you who participated. Have a great day.
Thank you.